foreign public policy. And we are just going to record his section of the presentation, and then we'll turn that recording off when we get to the discussion part. So hopefully that is okay with everyone. But I have told you, so hopefully that's okay. So with that, I'm going to go ahead and hand it over. And Zach, the floor is yours. Take it away.
Great. Well, hi everybody, and thanks for coming. I'm really appreciate you guys taking the time. So, Healthcare Affordability Lab is a new initiative we launched at Yale. It is to basically use the best scholarship we can to hopefully push forward and assist with public policy that makes healthcare more efficient and more affordable in the U.S. A lot of the research I do is thinking about the causes and consequences of rising healthcare spending domestically. And in turn, we focus a lot on the hospital sector. So I'm going to share some of the work that we've done recently, thinking about how growth in hospital prices is affecting health spending on the privately insured. And then in turn, talk about a new tool we have out that hopefully is useful to the folks in this room is think about which mergers out there are problematic and how we can think about it. So I'm going to share my screen and I'll first share with you I'll give a little talk about it, and then we'll dive into the tool that we've built. So, for a bit of context, and I think this is really, really important to talk about. So, annual premiums for a family of four right now with employer-sponsored health insurance, about $27,000 a year. We've seen premiums go up pretty substantially over the last 2 decades. And one of the things I think is incredibly important to point out, it's about 92 to 95% of the growth in insurance premiums are driven by growth in healthcare spending. So if you want to make premiums more affordable, you've got to make healthcare more affordable. And depending on how you measure it, this is going to be data from HHS, about 30 to 40% of healthcare spending is done in the hospitals, the plurality of healthcare spending. So I, in a sense, focus on hospitals, not because of some profound interest in hospitals, but rather like the same reason that folks rob banks, right? It's just where the money is. And the reason we want to focus so much on the hospital sector, both is because of its size, but also because of this graph, which is pretty straightforward. It's just taking data from the Bureau of Labor Statistics. And what you see is that prices in the hospital sector have grown faster than prices in virtually every other sector of the economy. So when we think about what's making insurance premiums go up across the country, it's growth in healthcare spending. When we think about why health spending is going up, the biggest chunk of it is hospital care, and hospital prices are going up faster than prices anywhere else. And part of the driver, it's not all of it, but a sizable chunk has been the consolidation that's happened in the hospital sector over the last 25 years. So what we're going to show here in the blue lines is just the number of mergers. So you're going to get sort of 40 to 50 mergers a year. It actually almost looks like the mergers have slowed down in 2016. And that's true that there are fewer mergers, but in fact, the deals have gotten bigger. And in some ways, this is mechanical. So basically, a lot of the singleton hospitals got gobbled up in the first part of the 21st century. And now you're seeing fewer but bigger transactions where instead of buying the singletons that you would have bought in 2002, now you're buying sort of 3, 4, 5 hospital systems. What's really important I want to flag here is that set of red zone mergers. So these are mergers which run afoul of the Federal Trade Commission and Department of Justice's merger guidelines. These are transactions based on the change in what's called the Herfindahl-Hirschman Index, which is a measure of concentration that the DOJ and FTC think, well, presumptively are going to raise prices by lessening competition. About 20 of these a year. And then you see enforcement actions there at the bottom, and there have been very, very little. So you want to think about is across the country, each year, there are about 20 or so mergers that are likely to raise prices by 10, 20, 30% happening year in and year out. And you can sort of, I think this is one of the sort of key points I want you to take away. Not all mergers are bad. What we really want to think about is which mergers are the ones that are potentially going to raise prices by lessening competition without generating any changes in quality. So on the left, this is showing the price effects of mergers that don't change market concentration. So these might be hospitals that are located a pretty good distance from one another. And you see that looking at these mergers, and this is the biggest chunk of them, they don't raise prices very, very much. But that chunk that do lead to meaningful increases in market concentration are leading to 10% on average increases in price after 3 years. Outside of the hospital sector, I think we have a pretty good feeling for what happens when two companies merge, right? If Mars and Hershey's come together, like our candy bars are going to get more expensive. I'm going to have to pay more for them when I buy a snack this afternoon. It's different in the hospital and healthcare sector because most of our spending is done by private insurers. Moreover, the plurality of individuals in this country get their health insurance through an employer. And that changes the effect of mergers in very, very important ways. What it does is it creates a mechanical link between what's happening in our healthcare markets and what's happening in our labor markets. So economists typically think that when workplace benefits become more expensive, it's actually the workers who are paying for them. It isn't the benevolence of Yale to give me a parking spot. It's actually, in a sense, taken out of my wages. And when benefits become more expensive over time, we think that that reduces workers' wages. And there's a pretty good body of evidence that suggests that that's what happens. What's different here is the assumption that when benefits become more expensive, wages go down is predicated in the idea that workers value the benefits they're getting. But when most of the increase in spending is driven by price increases, not quality changes, we might not think that workers are valuing it. And when workers don't value it, we actually think that instead of leading to wage reductions, it might lead to job losses. And so that's what we've looked at in some of the work that I've done. Moreover, there's lots of reasons to think that when healthcare spending goes up, it's actually lower wage workers who are the ones who may potentially lose their jobs. And this is for the following reason. Wages inside a company vary a whole lot, right? The person in the C-suite makes a whole lot more than the person in the mailroom. But it turns out insurance premiums actually don't vary by that much. And so we can take the average person with a college degree and going to make about $100,000. The average person without a college degree is going to make about 50. Both are going to have insurance premiums at about $9,000 a year. If you're a company, you can let $100,000 a year worker go, and you're going to save the $100,000 in wages and then $9,000 in premiums. Or you could let two $50,000 a year workers go. You're going to save $100,000 in wages, same as that one, but you're going to save $18,000 in premiums. So it sort of highlights how the incidence of healthcare spending probably falls disproportionately on lower wage workers because it makes up a higher proportion of their pay. And that's something that I test out in some of my work. So I have work that I've done with Stuart Craig and Lev Clarnet, Itai Lurie, who's at the Treasury, and Corbin Miller at the Treasury. And what we're trying to think about is how increases in healthcare spending on the privately insured have affected insurance premiums, what happens in firms, their payroll, their jobs, and then some of the downstream consequences like inequality and mortality and tax revenue for the federal government. And this is actually pretty tricky to measure because it might be that when a company like NVIDIA starts doing really well, they buy more generous insurance coverage for their workers, and that in turn leads them to spend more on healthcare spending or more on healthcare. And so what we've tried to do is say, look, let's trace through the impact of hospital mergers and see how that affects things like private spending down the line to things like the payroll and the employment at, say, manufacturers nationwide. And the way we do that is by getting access to a remarkable set of data from a couple different sources. We're going to have claims data from 3 of the 5 largest insurers in the US. And then we're going to work with the US Treasury via a program they set up for a handful of researchers that gives us access to the universal tax returns from the IRS. And that gives us a really rich picture of what happens inside counties, and what happens inside companies, and what happens actually inside households nationwide. And what we do is we say, okay, well, what happens when hospitals merge? And we can go through the methodology if folks want to in the Q&A, but we're going to think about how exposed different companies are to the mergers that have happened over the last 2 decades here. And what you basically see is that when hospitals merge, prices go up and premiums go up. It's a dollar for dollar pass through. So when a hospital raises its prices by 1,000 and spending at that hospital goes up by 10,000, let's say, insurance premiums for folks locally go up by that amount. It's complete pass through from the price increases from mergers onto the increases we see in premiums. What's critical is that this in turn is leading to job losses and wage cuts for those outside the healthcare sector. And that lower wage workers are the ones who are losing their jobs. And what we can do is use our estimates and calibrate how big an effect this is. And because most people get their health insurance through an employer and health spending is going up over time, it actually turns out that the way we fund healthcare together with the growth we're seeing domestically in healthcare spending is actually the leading driver of income inequality in the US over the last 50 years or so. Right? So if we take a step back and we look across the country, one of the biggest issues we're facing as a nation is income inequality. Growth in healthcare spending and employer-sponsored health insurance is what's driving that inequality, on par with contributions of things like trade and outsourcing and automation. We can see what happens to the folks who lose their jobs. They do not fare particularly well. This isn't just us, but most of the academic literature finds that about 1 in 300 of the folks who lose their job tend to die within a year. Turns out losing your job is just devastating economically and socially. We see that. We also see things like tax revenue go down. So, where are we now? Health spending, it matters. Premiums are high. Premiums are high because health spending is up. It's hospital spending that's driving the premiums, and hospital mergers are what's driving hospital prices to increase. And there's this tranche of mergers that we think are very, very problematic. So what we want to do is try to give policymakers some tools to think about what markets look like in their area and how to evaluate some of these transactions going forward. And so we've introduced a data visualization. Move this a little over. And what we've done is created a database of all the hospitals nationwide. It turns out this is actually a little harder than you would think. But we're going to have a website. We'll post a link here in the chat. And for every dot, we're going to have a dot for every hospital. It's going to show the number of beds at those hospitals. And what we're going to do is go out and we're going to measure the market for each hospital. So there are different ways that you can do this. This is, I think, a fairly standard approach, which is we're going to look in a 30-minute travel time in all directions of a hospital. So any hospital's competitors are going to be those that are reachable via a 30-minute drive on a weekday at noon from the hospital where we're focused. That's going to allow those markets to get physically bigger. In rural areas, they're going to get pretty small here in urban areas like where I am in New York City. And what we're going to do is then measure market concentration in each of these areas. So a Herfindahl-Hirschman index is going to be the measure of market concentration that we use, the Department of Justice uses, most folks use it. And it's the sum of the squares of the market shares, which is a sort of mouthful, but you look at all the market shares of all the firms in a market. And if it's perfectly competitive, which it never is, it's going to be 0. And if it's a pure monopoly, it's going to be a market share of 1, which we're going to say has an HHI of 10,000. And we're going to do this for every hospital across the nation, every year from 2000 until now. And so you're going to get a map that looks like this that you can play with, and you can see how different states match up and how these have changed over time. And again, the FTC and the DOJ are going to say, look, mergers with an HHI over 1,800 are going to be ones that we should be concerned about. That's true across the board in the economy. I'm going to sort of say ones that are above 4,000, the ones you really should be concerned about for hospitals in your areas. The next thing we do is we create a database of all of the mergers that have happened between hospitals nationwide. And we're going to look at all the mergers from 2000 till now. We're going to flag the ones that look like they're the ones that raised prices by lessening competition. So those that the FTC thought were happening in the red zone. And then we're going to update this. We're about 2 months lag. So it's going to be all the way through, I guess, at this point, it's probably something like April, or it might be March 2026. Although we're going to do a new update in June. It might be every 6 months. So I think we have a 6-month lag. See Andrea nodding. So there are really going to be two uses for what we have. So the first is just characterizing what's happened in your area. The second is seeing which mergers prospectively are problematic. So I'm going to show you both of those features in our visualization tool. So the first thing we can do is start at, say, a state level, and we can characterize how much change in concentration states have experienced. And it turns out my home state, Connecticut, has experienced a whole lot of market concentration. Now, there are states like Vermont that were concentrated, that have remained concentrated. States like Utah that were concentrated, remain concentrated. California actually, as these things go, is doing decently well. Connecticut has seen some challenges, right? We've gone from actually being pretty unconcentrated, decent degree of competition, to being quite concentrated over a 25-year period. So Connecticut has seen a surge in insurance premiums over the last 23 years. It's actually deeply problematic. We have some of the highest premiums nationwide and some of the highest spending growth. And you can actually, I think, in practice, see how this has occurred in the state. So in 2000, there were 32 hospitals in Connecticut. There were actually a handful of hospitals that are here in yellow that actually are facing a decent degree of competition. There's only one monopoly hospital, and this is not great, but it isn't terrible. Since 2000, this is actually 2010 to 2019, there have been 20 transactions. 7 of those were what the DOJ and FTC would have said are likely to raise prices and lessen competition. There were 18 hospitals in our state of the 32 that were involved in one of these transactions. So basically, in 10 years, more than half the hospitals were involved in a transaction that the FTC, based on their own guidance, would have said are likely to raise prices by lessening competition. And here's what this looks like. So Hartford Healthcare, at the beginning of the century, 3 hospitals, an average concentration of 2,300 points. Over the intervening 25 years, they bought a whole lot of their competitors. They now own 10 hospitals. Their average concentration is pretty high. We can look at my own, the academic medical center affiliated with Yale University, Yale New Haven Health System. It went from 3 hospitals up to 7, including buying our nearest competitor in New Haven. And this is a deal that probably raised prices by about 20% for residents in the New Haven County. What has that meant in practice? 97% of hospitals have experienced a significant increase in concentration, an increase the FTC and DOJ think are likely to lead to price increases. The only hospital that didn't experience a significant increase in concentration was the one monopoly that was there in 2000. So this is one of these sort of things that you just don't really want to see. We're in an environment now where 10% of hospitals have an HHI of 5,000 or more. So this is a tool that's going to let you go back to your state and say, okay, how did we get, where are we today and how did we get here? What we also want to do is give you the ability to say, okay, well, what happens and what about these deals coming down the road? And so I'm going to walk you through some of the functionality in our tool for the next couple minutes here. And what it lets you do is simulate the effect of a merger. So let's use the West Virginia University Health System and its merger with Penn Independence Health Systems proposed transaction, and see what impact that would have on concentration. And the reason we want to do that is so that journalists know which mergers are problematic, advocates know what mergers are problematic, state policymakers know, and attorneys generals can know. And it's also a tool the FTC can use to do some of their merger screening, which I think they're doing now. So I'm going to share my screen. So I'm going to turn this off. I'm going to switch. This is going to be our snazzy website. You can go and we've got everything documented there. And let's just go actually to the Market Explorer. So what I want to do is just first, so this is where you'd start if you just wanted to see what your area looked like. Let's just look at West Virginia, just because we're going to, West Virginia. So you can punch in West Virginia. Let's go to the state. Unsurprisingly, a pretty rural state, so a pretty decent degree of concentration. You see some monopolies here. right? You can put your pen over it or your cursor over it, and you see the West Virginia Medicines, Potomac Valley Hospital. This is going to be a pure monopoly based on our market definition. We can see the change in concentration over time. It actually looks like it was pretty concentrated in 2000. It stayed pretty concentrated. But what we're going to be able to do is now go to our forecast lab. And I'm going to move the screen here just a little bit. So let's look at this West Virginia merger. So we'll go to the West Virginia. Actually, I can just click on it here. So if you want to see the effect of a merger, and you can look at the effect of a merger, look at the effect on openings and closures, and see what that would do to market participants. So we can search in there for a hospital. Okay, so university's health system. You can see that's going to be a 21 hospital system. We can enter in, it's going to be Independence, which is actually going to be right here. It's already pre-populated. We can click on execute action. And what you're going to see is, lo and behold, this is going to be a transaction that's going to raise HHI. One of the merging parties, the Excella Frick Hospital, which has previously been in Independence, is now going to be able to be part of the West Virginia system. And this West Virginia Medicine Union Hospital is going to experience an increase in HHI of 450 points. Both of these are what the FTC and the DOJ are going to think, based on their traditional merger guidelines, are likely to increase prices by lessening competition. And we can click on the Excella Frick Hospital. It's going to center on it. So let's see here. So it's going to be centered on that. And you can see this is actually the West Virginia Medicine Uniontown Hospital, where the merger is going to overlap. And so this is a fairly conservative market definition. It is going to think it's a competitor. If you were going to do a merger enforcement, you would do this slightly differently, but this is going to give enough of a clue that this is the type of merger where, if past is prologue, we're probably going to see some price increases in the wake of it. And so the idea is, when this merger gets proposed, folks in West Virginia can hop it on in here and say, okay, based on what we're seeing, what do we think is going to happen? Now we can juxtapose this, and I'll wrap up here in a second, with a different merger. So it's going to be a merger actually that we're seeing in North Carolina. So let's look at North Carolina right now. North Carolina. Cities, states, North Carolina. Okay, so North Carolina, we can go over to state. Let's go to the Market Actually Explorer. It's a little easier. Yeah, it's a decently concentrated hospital market. If we look on the right here, you can see all the mergers that have happened. But a decent number of transactions since 2025. So since 2025, 51 transactions, 14 red zone mergers. And we can look at the merger that's getting proposed now between Atrium and WakeMed. So this has been in the news actually quite a bit. So we can put in Atrium here. Got 23 hospitals. We can pump in WakeMed, I believe. And it's 3 hospitals. We can simulate the merger, and you're actually going to see that HHIs don't actually change. So based on our market definitions, these don't look like they're overlapping, at least with respect to a 30-minute travel time. So this would be an example of a merger that does not appear to be of immediate competitors. We can go back to the slides, and I'll just finish off, and then we'll open it up to Q&A. So the idea of the tool is basically to give you the ability to look at these transactions and do a first pass of thinking about how likely they are to raise concentration and in turn raise prices. Over the next year or so, we're going to be putting out a series of other tools. We're going to have a tool that's going to come out pretty soon that's looking at hospital openings and hospital closures over the last 25 years. I did not expect it. There actually have been a whole lot of hospital openings. We're going to show where those happened and there have been certainly more closures. We're going to do a tool that visualizes insurance premiums over time and the share of it that's driven by the markups in premiums versus an increase in health spending. And then we'll put out a tool shortly on hospital prices. We're also going to try to get some information up on the website on physician market concentration. So just taking a step back, I think if there's one takeaway from the remarks today, if we're serious about addressing the cost of health insurance, we've got to focus on the cost of healthcare, and that chiefly means focusing on hospitals' prices. The hospital markets nationwide have really been transformed over the last 2 decades by a series of mergers that have left most markets less concentrated, or excuse me, more concentrated, less competition, and higher prices. What are we going to have to do going forward? Basically, there's a fork in the road. I think part of it is going to be encouraging competition, and we can think about ways to do that. And that's, I think, chiefly going to be about bringing other types of providers into the market, getting patients comfortable traveling longer distances. It's going to be about stopping potential harm in the future. So that's avoiding more transactions that actually lessen competition. And then it's thinking about what to do in markets that are already concentrated. And so there are about 20% of markets nationwide where there just isn't competition. My own view is competition is good. Market determined rates have lots of virtues. But once you are in a monopoly market, competition can't do its thing. And we really should be thinking about how you regulate prices in that sort of 20% of markets nationwide. So with that, about 3:45, I'm going to open it up to questions. We can talk about the tool. We can talk about hospital concentration, hospital pricing.